everyone. Today we are doing a Just Thinking with Dr. Seema Vijaywargiya and Dr.Neerja Pauranik. Both are the senior obstetricians of the town. Dr. Seema Vijaywargiya is practicing OBGYN from last 35 years in Indore. And she has got a tremendous experience who practices evidence-based medicine and is a very thoroughly knowledgeable and honest gynecologist. And another is Dr. Neerja Pauranik, senior OBGYN, practicing from 32 years in Indore, was a senior consultant at Bombay Hospital, and now practicing as her own. And also she has got a tremendous work in a gynec also. She is a gynec surgeon and a practicing OBGYN, and both of them having a seriously in love with breastfeeding and the lactational things. And all of us will have some few questions with them and we'll talk about. So first, I'd like to ask Dr. Seema Vijaywargiya, madam, that can we feed the baby with a cow's milk? What's your opinion regarding this? See, this is a breast feeding things we are talking about. What are the myths? What are the facts? How we are talking about how the things will be. And these are the small thinking thing. So we'll do the spontaneous question answers, and it will be one-to-one and in a very little sentences. Both the men and speakers will speak. Seema Didi, can we feed the baby with cow's milk?
Good afternoon, everybody, and good afternoon, Kawita. Thank you for giving me this opportunity. Yes, people are feeding the babies with cow's milk, but cow's milk is good for cow's baby. It is not good for human baby, because human baby is designed to develop in a different way. Cow's baby is gaining its birth weight, doubles its birth weight in 47 days after its birth. But the human baby will double its weight in 6 months, because the other thing which is important in human baby is development of the brain, and the brain triples in the size in first 2 years. So brain development is very, very important in human babies, and the milk is made like that the brain development can be taken care of. And in this case, what we have seen is always the mammal's milk are species specific. In cow's milk, there is some beta albumin, which is, and casomorphins, which are responsible for the muscle gain and for sleeping, basically sleeping of the baby. And in our this thing, the other factors are there, so the baby's brain can develop.
Correct. So for the development of the baby, we should go for the species specific milk. That's very, very important. We should not go for the cow. We as a mother is there. So Dr. Pauranik, can you tell me if there is enough milk for first 3 days? What we heard about all the time. कि पहले 3 दिन में दूध ही sufficient नहीं होता है. What's your opinion regarding this?
This is a very good question and a very practical question also, because everyone thinks that there is no milk coming in first 3 days. Everyone knows the importance of breastfeeding. Everyone knows that we have to exclusively breastfeed for 6 months, but somehow the milk which is coming in drop by drop, they think that it is not sufficient for the baby, and which is a great myth and misconception in all of our minds. And Kawita, the first day, the baby's size, the size of the stomach of the baby is only cherry. That is 5 to 7 ml size. And on the second day, it increases, and the third day, and by the end of the 1 month, the size of the stomach will be increasing like a size of the big egg, which is like 50 ml or something. 80 to 150 ml.
So you mean,
expecting a mother extracting a milk of 150 ml on day 1 is ridiculous. So you should not press upon the fact that the milk will come in flow. The colostrum will come in drop by drop, and that is only sufficient for the baby.
Okay.
And this colostrum, yes.
I'm sorry to interrupt between, but I like that the answer should you just give the precise so that the mother, you mean that for 3 days, the milk which you are talking about as the stomach size is very small. So it's enough for the baby as according to you. Am I right? And what we like to
fluid in the body.
Yeah.
The baby, the nature has given 20% extra fluid in the body of the baby So we should not worry about the
Okay.
baby. Let them tackle themselves, means the baby and the mother duo, and figure out the things in first 2 3 days.
Excellent,
So
excellent.
that should.
So whatever the amount of the milk is coming, it's enough for the baby. Absolutely right. Seema Didi, will you like to tell about this? What unique factors about human milk? Make your answers precise and small so that it should be to the point and good for the audience.
Breast milk is very unique. Apart from the fuels of carbohydrate, fats, and proteins, it contains lot many other factors which are responsible for the immunity of the baby. Carbohydrates are different in the way that they are lactose, and 40% of the energy comes from them. And lactose is equally important for making good secretion of the milk, because whenever the breast alveoli contain the lactose, it actually sucks out the fluid from all the peripheral circulation and makes copious secretion in the breast. So it is responsible for milk coming in, mature milk coming in. Secondly, the proteins which are present in the breast milk are mainly whey proteins and not the caseins. And that is a very digestible form of protein, and it is important for the brain development. The fats are also different. They are more mainly triglycerides and cholesterols, and they are actually, it is very important to know that the cholesterol which is there in the breast milk is not present in any other formula or any other thing. So these babies can handle cholesterol very well in later life. And the uniqueness is that even if a lady is from the African village of a very malnourished category and she is from a very affluent class, the milk constituent, especially the protein, will remain the same for both the milks. So this is the best and unique feature of the milk, human milk.
Correct. So
and apart from this, there are many vitamins, minerals, growth factors, lysozymes, lactoferrins. There are so many things which are responsible for the good development of the baby.
So unique factor of the human milk, you mean the right amount of carbohydrate, fat, protein, and all the nutritional amount and the antibodies. It's really a great thing. Dr. Neerja, will you like to talk about the baby's demand about the excessive feeding? They go on talking that the whole night, every 15 to 20 minutes, the babies cry. And the mother also cry, the mother-in-law also cry, everybody start crying. So are you worried about this part as a lactational consultant and having a great degree you have? So what's your opinion regarding this?
Others are, Kavita, are coming to us for complaining this, that as for your advice, I'm doing exclusive breastfeeding, and now my baby is demanding tremendously the whole night. Every 15-20 minutes, she or he is demanding the milk. So sometimes you have to sit by the side of the mother and be passionate, and then you have to listen to the story, and then you can come out with the fact that this is nothing but the growth spurt. So after 15 days, 20 days, there are growth spurt. The baby don't grow like steep. They just grow like this. Sometimes they are stable, plateau, and then again the spurt will come. So this is the growth spurt. So the baby demand endlessly, and you have to teach the mother-in-law, and also नानी दादी हर एक को बताना है कि ग्रोथ स्पर्ट है और आपको इसमें चिंता करने की बात नहीं है. आपको एंडलेसली अगर डिमांड है, डिमांड फीडिंग कराना है, और फिर क्या होता है, 2 दिन में 1 दिन में ग्रोथ स्पर्ट चला जाता है, एंड देन सडनली द बेबी बिकम क्वाइट, एंड so quiet that the breasts are full and now the baby is not demanding. So these are the growth spurts we have to take care of.
So you mean in a nutshell that we need patience, our patient need patience, their mother-in-law need patience, and what about the baby? Baby also need a little patience to learn and update themselves. I agree with you. So as an obstetrician, Seema Didi, you're working so many years and having so many patients or obstetrics and dealing with them. So do you think during the period of pregnancy, it's your job to make them train that what is the antenatal priming we should think of, and what points you will like to tell them that they should do for the good breastfeeding after the delivery and everything. So during your OPD timing, how you prime your antenatal patients for the
This is very,
breastfeeding.
very important. Yeah, yes, this is very important. Successful breastfeeding will only continue if we do our antenatal priming as well as postnatal support. And also we should look after during the labor. So antenatal priming is necessary, and for that we usually teach the patients during our OPD timings. We have some questionnaires prepared for them. We give it to them, let them fill it, and then we discuss each point with them so that they can understand what they have written, what is wrong and what is right. Secondly, during this discussion, I always like the mother, mother-in-law, husband, or whosoever will be taking care of the baby, and the mother should be present, and they should all know about it so that it doesn't happen like that सब लोग अलग-अलग सलाह दे रहे हैं. Then she is very much confused. So we require the whole family to be counseled about breastfeeding. And there are many questions in their minds, like will I be able to feed, or will it hurt, or how long I should continue, or will my milk be enough as she has told already. And they have so many questions in their mind, and how should we prepare for breastfeeding? Do we need this gown? Do we need this preparation? Everything. They have so many questions in their mind, and those questions are to be addressed during the antenatal period. And I have seen in my practice that when you do antenatal priming and give a postnatal support, usually these people are very, very successful in breastfeeding exclusively for first 6 months. And I'm very happy to see them.
Correct, correct. So as being with your knowledge, with your patients and with your patient, you always do a right counseling. It's not the counseling and examination of the breast, everything, but the counseling of the family. And a pediatrician's needed sometime while doing this type of counselings for the breastfeeding. Should we add them in our practice group to come and also the counsel? Because sometimes some of the babies are going to the premature one, some are going to be the post-mature one. There may be some other things. So sometimes we may need this. Do we need some special counselor for the antenatal priming of the patients? As a general obstetrician, I'm asking you.
I do it myself. So
yeah,
I do it myself. So I feel I am the best person to do that with my patients because they have a good rapport with me.
Correct.
So whatever I talk, they believe it and they feel confident. The whole aim of this antenatal priming and postnatal priming is making the person happy, confident, and proud that she is breastfeeding. So that's why you need to do it.
Correct. So nice of you. So because of the right counseling, and patients started having a breastfeeding during the postnatal period. But Dr. Neerja, do you have any points and suggestion about the engorgement of the breast? Anything you like to talk about the engorgement of the breast? See, I am mixing both the questions in a different manner, but these are the questions which are the breastfeeding patient needs, patient counseling needs, and we are supposed to address all these questions and answer all the answers about this. So what do you like to talk something about the engorgement of the breast?
Yes, engorgement is a condition which very often it's very common in primary patients, those who are pregnant for the first time, delivered for the first time, and they don't know how to feed and how to latch and everything. So the engorgement is very common. And conversely, what happens in the engorgement, they advise the healthcare workers, they advise garam pani ka sikai kar lo. That is very wrong. So in engorgement, there is a very simple technique, very simple. We call it as reverse pressure softening. So I have a breast model here, and can you see?
Yes.
Yeah. So the patient is lying supine, and you have to just press softly. What is engorgement? Engorgement is the collection of fluid, the collection of two types of fluid, the lymphatics as well as the milk also. So there are two compartments, different compartments. So as you are, your patient is lying supine, and you just compress very softly the breast in a circular fashion. So what you are doing is you are pushing the lymphatics and the extracellular fluid into the chest wall and in the axilla, and at the same time, if you are just pressing the areola and the nipple softly, you are creating a MER, the milk ejection reflex. You are stimulating the nerves behind the nerves which are lying beneath the areola and the nipple. With the MER, what happens? There is a milk ejection reflex. The oxytocin is liberated, and it is acting now on the breast. And with the pressure, you are pushing the milk into the milk ducts. So now the areola is free. The areola becomes supple, and the areola will be easily taken in the mouth of the baby. And you just press like a burger, so that it is directly into the nipple is directly touching the
left
touching hard palate,
the palate.
Palate. Okay, so it should go right inside. So where the soft palate and the hard palate meet, the junction of the soft and the hard palate, and the breast becomes soft, and the two fluids are linked in that they are pushed in the different compartments. And in the engorgement, we also advise the cold compress, not the hot compress. And sometimes these cabbage leaves, they also they are very helpful. So the पोटली में जैसे पीस बांध लिए या फिर दाने उसके चने के दाने करके और ब्रेस्ट को आप अगर cold compress करो तो they are very help. It's also very helpful in the engorgement.
Your passion for breastfeeding is so much, and it's so infectious. Probably after listening about the engorgement and everything, I think the rest of the obstetricians who are listening this, they will like to invite you and to treat them for their patients. I'm really appreciating your passion and your infectious attitude for breastfeeding. So Seema Didi, I just want two questions one-to-one from you. What do you believe in skin-to-skin beneficial is just after the delivery, and another thing is a breast crowd? You really like to talk something about these two things? Is it because nowadays we all the things things are very, very popular about the skin-to-skin, what they call it, it's skin-to-skin touch, you can say, and another thing is the breast crowd.
Oh, the skin-to-skin is very, very, very important. It should be not for me, but it should be for everyone. What is skin-to-skin? The naked baby, immediately after the birth, the naked baby is kept on the chest of the or abdomen of the mother and is covered with a dry cloth, and his head is covered with some topi type of thing, so that he doesn't lose much of temperature loss is not there from his head. And this forms a cocoon type of a thing, like the baby is on the abdomen of the mother, and in this situation, I think the baby is the mother's center of the world, and for the baby, the mother is center of the world. So they become one at that time.
Correct.
And that not only that, it has not many benefits. One thing is baby is colonized with the mother's bacteria first. Because mother has antibodies against her bacteria, so it helps to see that the baby will be infected by mother's bacteria only, rather than pediatricians, bys, nurses, or anybody else. So that is one important thing. Secondly, it helps regulating the respiration, the heart rate, and temperature of the baby. And this was started when kangaroo mother care was started in Australia. So the premature babies were kept to the mother's chest so that they are thermoregulated, and they never needed so many incubators. And then they thought that this is the best incubator provided by the nature. So that is one thing. The baby feels secure, warm, and the heart rate becomes normal. At the same time, when this skin-to-skin occurs, there's the innate response of the baby to seek for the breast. That is his main aim, that he has to seek for the breast, because he has only one work, to go towards breast and have feed. So that innate response is also initiated. This also develops a lot of bonding between the mother and the child. Leave aside India में तो हर mother को bonding बहुत ज़्यादा है अपने बच्चों से, but for the other ladies also, this skin to skin is very important in increasing the bondage. It is said that if mother is very unwell, then the father can also give skin to skin. That is also very important. And in skin to skin, when the baby is remaining for that for longer time, the baby on its own starts feeding, and it doesn't require many things to teach them latching and everything. So that is one skin to skin. And what is breast crawl? Breast crawl is a very amazing phenomenon, very wonderful. I have seen the videos and one should see them. It is like a predictable sequential pre-feeding behavior of the baby, in which the baby, if left in skin to skin contact with the mother, the baby tries to reach the breast on his own. He starts kicking with his heels and tries to reach to the areola. How it occurs? Because the amniotic fluid in which the baby is has a similar smell as the breast milk is. So with that smell, the baby goes towards it. There are many factors which are auditory, because mother is speaking to him. Secondly, visual, he's trying to locate the areola. And thirdly, that auditory, which is he's trying to locate that milk, and then it starts crawling towards the breast. And this may take 50 to 60 minutes, but it is such an amazing phenomenon that without even putting the baby to the breast, the baby seeks the breast and reaches the breast. And this sensation, the tactile fixation,
invoking all the senses.
For the mother, it is very beneficial. It reduces PPH, it increases bonding, oxytocin is released.
You mean amazing phenomena. You mean it is
amazing, wonderful. When I saw it first, I was amazed.
More spiritual, invoking all the six senses. I think it's a really phenomena. Yes. So you mean we have to be a skin to skin to the baby as well as baby crowd, and to keep the baby with mother. So the rooming in has got a great role along it. So the Dr. Neerja, will you like to talk something about breast milk jaundice? Anything like about that? Do you believe in it? Is it there or not? And if it is there, how has to be treated? And what is our role when the baby is having the breast milk jaundice?
We all know about the physiological jaundice, which is there commonly we see. But this breast milk jaundice comes 10 days or 15 days after the delivery, after the birth of the baby. And recently only I had one doctor couple whose baby was having breast milk jaundice. She was discharged on the third day as usual. And then again came on 4th, 5th day with the physiological jaundice. We gave her prototherapy. Then the baby went home. And on the 10th day, the bilirubin of the baby started increasing. It was 12, 14, 16, and they got panic. So they consulted 4 or 5 pediatricians, as the doctors are the worst patients. So the multiple consultations, but the answer was same with all the pediatricians, that this is breast milk jaundice and we have to stop the breastfeeding for 48 hours. And she was hardcore breastfeeding person, so she was not ready to accept this, that I must stop breastfeeding my baby for 48 hours. So she consulted out of Indore also some pediatricians who are pro breastfeeding persons, and then they advise.
Hi, in conversation with Dr. Seema Vijaywargiya and Dr.Neerja Pauranik, we are back. So the few questions to both of them. The first question to Dr. Neerja Pauranik. Dr. Neerja, do you sometimes believe into formula feeding, though you are a hardcore thing? Then and which conditions you will prefer, or in not a single condition you will prefer the formula milk to the babies?
It's a very hard question for me, and I I'll never prefer formula feed. I'm very much against formula feed, but we can have other options also. We can ask some other mothers to donate the milk. Otherwise, there is no question why the milk is not coming. So this is, I think, very typical and hard question for me to
Actually, being a hardcore breastfeeding supporter, you will say there will be no such condition where we'll need the formula milk. Am I right? Like that. But in some conditions, if she is not able to, then she can have the milk from the breast bank, milk bank or something like that. And
milk bank is the answer. Yes.
Yeah, milk bank is another answer. Some other person can feed her, and until and unless she is having this problem. So I appreciate this point. Seema madam, as you have said so much about the skin to skin, breast crawl and anything, and a nicely counseling of the patients throughout the pregnancy, and made your patients to having this thing. Any other point which you will like that our audience should know about the breast? So this will be a concluding question from you, that what other thing which you like to talk about the breastfeeding to me?
Actually, these days the trend is you deliver and you go home. But I always think that the breastfeeding should be established before the patient leaves for the home. Because it is important. She will not be able to do it because she is also immature. So she will not be able to do it. So we have to teach her one thing. Secondly, we have to teach our staff that not to say, "Arey, doodh hi nahi aa raha hai." They should be very supportive. Third thing, we should call them for a follow-up after 1 week so that we can see what we have taught is being practiced or not. That is the key for exclusive breastfeeding for first 6 months, which is WHO motto also. So these three things are to be done. And when many people will come and say, "Doodh kam pad raha hai," which we have already talked. But we have to tell them that there is something like autocrine control in the breast level. It is a local regulatory system of the breast. And the breast is the only gland which is not dependent on any stimulus from the central nervous system or from the systemic circulation. It is secreting the secretions on its own. And it is when the breasts are very full, then the mammary epithelium becomes flattened and feedback inhibitors are present in the milk and the synthesis of the milk stops. And as soon as the breast is empty, these feedback inhibitors go away and the breast milk secretion starts very fast. So the key is that we have to make the patient understand that how many times the baby sucks. It depends, and the milk production will depend on that only. More frequent sucking, more frequent milk will be there. This is the explanation for the twins and triplets also. The mother is able to feed the twins also in the same capacity because she has an autocrine control. How much milk you remove, that much milk is formed. This is also a very amazing fact of nature that it is never less for 2 babies or 3 babies. So it has to be told to the patient, it has to be addressed, and the patient should be convinced that she should be, because there are many things in their mind that my breast is small or my breast is heavy, my breast is small, so there will be less milk. It is not like that. If the breast size is small, she will have to make the feeding more frequent so that more and more milk is formed. So this is very important. So we have to give the importance of all these things, the importance of hind milk, the importance of fore milk to the patients, and ask them to completely remove one or empty one breast, because the fore milk is coming, which is very great in energy, but the hind milk is having fat, which is very important. So these all things are to be told while in the postnatal period and also on the follow-up.
Excellent way of putting things. So I think Dr. Neerja will like to say something, so then after that I'll conclude.
I have few points to ponder, that one should follow the golden hour and it should not be missed anyways. The skin to skin should be started as soon as the baby is born in the labor room and the OT also. And encourage breastfeeding in sideline position. I don't know why the people are not encouraging the breastfeeding in sideline, because the axis of the baby is like, while the baby is, the mother is feeding in sitting position, the axis of the baby is like this. And if the mother is lying down, sideline position, also the axis of the baby is same. So in labor, in normal delivery or in cesarean section, the pain is so much. The episiotomy pain is horrible, and the same is the cesarean scar. So the mother is not able to move. So we should encourage the mothers to sideline, to feed the babies in sideline position, and do not hold the baby's head and push the baby into the breast. Just hold the baby from this side and hold the baby from the nape of the neck, so that baby can move the head and latch properly. Then the other thing is, in the healthy baby, there is no need to do the blood sugar levels repeatedly, because it creates panic and it creates anxiety. And there is no need to treat the breast milk jaundice also, because the breast milk jaundice is only the extension of the physiological jaundice. So we should defer by say, we should not encourage the formula feed. Just stop breastfeeding for 48 hours and then you start. So that is also very bad. And the need of the hour is not to get into the top-up trap. So we should, and as an obstetrician, it's our duty to talk with the pediatrician and encourage our mothers for the breastfeeding.
Thank you.
And
A great conversation with Dr. Seema and Dr.Neerja Pauranik. They are a hardcore breastfeeding supporter, and that's the need of a time. According to them, we should not feed the babies with the cow's milk. The first 3 days, the milk is sufficient. The engorgement can be treated so nicely if it has been there, and we should be promoting skin to skin baby crawl and breast crawl, and the antenatal counseling has got a great role, and the patience is the end result for the good and breastfeeding. So thank you so much for the patient listening again about the breastfeeding, and any queries about the breastfeeding, I'm just putting the numbers of Dr.Neerja Pauranik and Dr. Seema Vijaywargiya so that you can contact them and you can ask your own questions. Thank you so much for being with us.